So everybody can see it, right?
Yes, we can see it.
All right, excellent. All right, so delighted and honored to give a talk on my favorite topic, recent advances in diagnosis and treatment of early Alzheimer's disease. I have no relevant financial relationships to disclose, and I do not intend to discuss any off-label investigative use of commercial products or devices. Two learning objectives. One is we'll discuss the role of biomarkers in early accurate diagnosis of Alzheimer's disease, and then discuss role of new FDA-approved medications for Alzheimer's disease. To me, aging is a privilege. Growing old is not a disease to be cured or defeated, but a privilege, tremendous privilege to be humbled by, to be grateful for. A privilege withheld from most of our ancestors and so many of our brothers and sisters. Let's become worthy of becoming old by falling in love easily, holding our heart gently, holding our fears lightly, and forgiving continuously. Why are we here? So I would quote Maurice Friedel and Christine Bryden. They are persons with dementia. They gave a talk at the Australian National Conference back in 2001. We seek to work towards transforming our culture to one honoring human dignity. Let's be companions together on this journey. So all our efforts are to honor dignity of individuals with early Alzheimer's and everybody else. Dr. Sue Borson is a big shot in the geriatrics dementia world, and she recently authored a paper. They look for rigorous evidence to see if detecting the problem of dementia early leads to better care, and they concluded that the rigorous evidence is lacking. Doesn't mean we shouldn't do it, but we have to just be mindful. Let me give you a case. This was published in the Washington Post, the story of Dr. Rebecca Chop. And now we'll see a lot of these new faces of Alzheimer's. Dr. Chop was diagnosed with early Alzheimer's disease in 2019 at the age of 67. I'm guessing that at that time she had MCI stage, mild cognitive impairment. After the diagnosis, Dr. Chop retired from her job as a chancellor of the University of Denver at the pinnacle of her career. So even at MCI stage, it's really hard to work at a very high level. She was also an ordained minister, a prolific author, and former president of Swarthmore College and Colgate University. So again, a lot of cognitive and brain reserves. When she got diagnosed, the neurologist told her she would not be able to button her clothes or feed herself within 2 years. And obviously, it's been 4 years, right? April 24, 2023 is when the Washington Post published this. So today she rises at dawn to take her dog for a walk, starts her daily routine of vigorous exercise and strict diet, and is passionately involved in painting, is on the board of directors of Voices of Alzheimer's, an advocacy group to promote the views of patients and try to gain access to treatments. And she helped launch along with Mr. Gudis. Mr. Gudis himself is a young onset Alzheimer's disease person. And again, these new faces are radically altering how we would view Alzheimer's disease. And Dr. Chop is currently working on a book entitled Art, Spirit, Body, Ways to Live While Dying from Alzheimer's. So I use this example to tell people that even after the diagnosis, one can lead a very full life. It's not easy. When she told her friends that she had been diagnosed with early stage Alzheimer's disease, her friends started talking more loudly. There was nothing obviously wrong with her hearing. She has stopped eating processed food and sweets and has adopted a vegetarian diet. So again, nutrition is big for brain health, but nothing new in terms of update. Dr. Chop made her husband, age 75, take back lessons. So again, a force to reckon with, Dr. Chop. And she had great friends. Her friend Anne Charlotte Granholm Bentley, a director of the University of Denver's Noble Institute of Healthy Aging, provided her with brain health and wellness guidance. So again, we should be doing this routinely, providing brain health and wellness guidance, nothing new. She has stopped driving at night, and sometimes she puts ice cream in pantry and salad in the freezer. So, one could make a case that if she was prescribed this new FDA-approved drug that we'll talk about, maybe she could have been driving at night for a little longer. Dr. Chop, while urging Medicare to cover lecanemab, so that Voices of Alzheimer's is very strong in advocacy to get Medicare to cover, and they succeeded. She herself doesn't take it and said that I have such good luck with lifestyle interventions. So regarding genetic testing, let's say if Dr. Chop came to me and said that, you know what, I've changed my mind, I'm interested in lecanemab, then I would recommend she get genetic testing for ApoE because if you're homozygous for ApoE4, then you are at very high risk of serious brain bleeds due to lecanemab. But otherwise, there is no update, nothing new in genetic testing. Again, Dr. Chop is white, so all these risk factors would apply. But if she was, say, Black or of another race or ethnic background, then I would remind her that the information we have of ApoE does not apply to your population. We are still learning. By the way, that lecanemab I'll talk about is also predominantly in white population. So we need to just keep that in mind. So today's talk is on early Alzheimer's. What does that mean? So there are two diagnoses one can give: mild cognitive impairment stage, the earlier stage before dementia, and mild dementia stage. And again, if Dr. Chop or somebody came and said, can you do one test and just give me a diagnosis of MCI or dementia? Then I would say no, because MCI and dementia are clinical diagnoses. I'll have to do a detailed comprehensive psychiatric evaluation, physical exam, do some office-based testing. If necessary, refer you for neuropsychological testing, check your functional status, do a workup, including brain scans. I would recommend doing MRI of the brain. Neuroquant imaging is what we do at Memory Center at St. Alphonsus to look for hippocampal atrophy. And then if all this is done, then I might give a diagnosis of MCI, probable Alzheimer's disease, or mild dementia, probable Alzheimer's disease. And then say the person wants to say, can you be more sure? Then I would say yes. Then I would have to do biomarker testing before I can be more sure that this is Alzheimer's disease. Especially if you want lecanemab, then we need to have biomarker positive. Then the patient says, sure, go ahead and do the test. I would explain that there are three different biomarkers. There are amyloid biomarkers, there are tau biomarkers, and there is biomarkers for neurodegeneration. And they'll say, all right, is that a blood test? I would say it's available, but it's not FDA approved, so the insurance won't pay for it. But if we did your blood test and the results came back that you had reduced plasma A beta 42/40 ratio, you have elevated phospho-tau levels, and you have elevated NFL, neurofilament light chain, or GFAP, glial fibrillary acidic protein, then this indicates that you probably have Alzheimer's disease. And then they would say, is that like specific? I would say no. If you want lecanemab, you would have to do a CSF testing. And it's FDA approved, I would tell them. We do this at the memory center. We have neurologists team who does that. And in the CSF, again, you would find the same thing, reduced A beta 40-42 ratio, but it's even better if you get your ratio of CSF phospho-tau and A beta 42. And if that's really elevated, then you have biomarker positive MCI due to Alzheimer's disease or mild dementia due to Alzheimer's. They say, I don't want any CSF testing, no pokes in my spine. Anything else? I would say yes. We have amyloid PET approved by the FDA. We can do that. We don't have it in Boise. You'll have to go probably to Seattle, is what I know. And in the future, we'll be doing tau PET. Currently, it's in the research setting. So that's a story of biomarkers for you. So again, in terms of how all this changes your clinical practice. Number one, if you have somebody with MCI or mild dementia, I would recommend that you say that now we have biomarkers available to be more sure that what the cause of MCI or Alzheimer's disease is. And either you would guide them or you refer them to experts who can guide them about biomarker-based diagnosis. And then, let's say we have a family member who says, I heard about this artificial intelligence based testing, and I would explain to them that, if you've had your MRI and your routine cognitive testing, then, this apparently will tell you that you have like 90% chance of developing dementia within 5 years or 50% chance. So in the future, we'll see more of this AI-driven, very complex algorithms that will take into account all kinds of things, including brain scans, genetics, blood-based biomarkers, functional testing, cognitive testing, family history, to predict future dementia probability. We'll switch gears to treatment. So again, in our treatment now, if we diagnose somebody with MCI due to probable Alzheimer's disease or mild dementia due to probable Alzheimer's disease, we would tell them that we have now an FDA-approved treatment for disease as a disease-modifying therapy that's new. And then if, let's say, they have agitation due to dementia, we would tell them we have a new FDA-approved treatment. If they have insomnia, we would say there's new treatment. And then another update is the CMS guide model, where if we provide this comprehensive care, there'll be increased reimbursement. So the patient says, all right, before I decide whether I want to do lecanemab or not, can you tell me a little bit about it? Yes. I would have to have you get biomarkers to see if you are biomarker positive Alzheimer's disease. If yes, then you'll qualify for lecanemab. It has full approval of the FDA. Are there any drugs coming up? Yes, another drug similar, donanemab, another monoclonal antibody is coming up and is expected to get full approval later this year. So what exactly is it, Doc? Well, it's a human monoclonal antibody. You'll be taking it intravenously as an infusion every 2 weeks for 18 months, 1.5 years. We'll have to get your MRI tested before. There are inclusion and exclusion criteria. So it's not a guarantee that you will qualify. And it's pretty costly. The drug itself costs $26,000 per year or more. And if you include everything else like MRI and doctor's visits and everything, it's 90,000 per person per year. And so, Doc, what are the benefits? So I would say that your disease will progress more slowly, which means that you will not see any improvement. You will not say, hey, I'm doing better with my memory or functioning. You will just have to have faith that if you're on the medicine, your decline is slower than if you were not on the medicine. And according to University of California, San Francisco, the slowing is by around 6 months after you take it for 18 months. And what are the risks? Well, there are risks of small bleeding in the brain or large bleeding. It's called ARIA, amyloid-related imaging abnormalities. Most of them are asymptomatic, but that's why you'll be undergoing periodic MRI of the brain. So what are the symptoms if I get symptomatic? Well, you might get headache, dizziness, confusion, balance problems, vision changes, diarrhea, falls, syncope. If you get any of this, you need to let us know, and you may have to get an immediate MRI of the brain to see if this is due to ARIA, amyloid-related imaging abnormalities, because if it is, then we may have to interrupt or stop treatment. Is it dangerous? Well, there have been reports of seizures and strokes. And can I die from it? Well, there have been 3 deaths reported so far. Any other side effects I should know? Obviously, whenever you get infusion, you'll have some adverse effects during that time and after that for a few hours. So tell me again, would I qualify? Well, if you're on anticoagulants, then no, there'll be much higher risk of bleeding. If you're homozygous for ApoE4, then probably you shouldn't get it, although some research centers may allow you to get it and then monitor you. If you have certain other MRI changes in the brain, like 4 or more microbleeds or 1 macro bleed or all kinds of other evidence of cerebrovascular disease or cerebral amyloid angiopathy, then you will be excluded from getting it. So that's so again, in terms of your clinical practice, I would recommend that if you have somebody with MCI, probable Alzheimer's, or mild dementia, probable Alzheimer's, you would say that we have this FDA-approved drug, and either I can give you more information or I can refer you to somebody who can guide you. Another update, and we can talk more about this, is if somebody with more advanced stages generally has severe agitation going on for more than a month, and they ask, is there any FDA-approved drug? You would say yes. Brexpiprazole is now approved for treatment of agitation related to Alzheimer's disease, dementia, or associated with. That's why you'll see this AAD as a new term being used. And then if you have somebody with insomnia, then one can say we have now an FDA-approved treatment for insomnia due to Alzheimer's disease, suvorexant. If you have a memory clinic, you should consider reading up about guide model and see if you can meet all the criteria, and you'll get higher reimbursement. Definitely you'll be able to provide more comprehensive care, but it has a lot of associated requirements, like things that you have to track. So it's, in our current healthcare environment, it's not easy. As I mentioned, I'm part of the team at St. Alphonsus Memory Center. Dr. Kara Coons is a geriatrician, is the medical director there. In terms of clinical practice, practically, I would recommend you check out this Brain Care Score. It's a freely available PDF, and use that for dementia risk assessment. Like if you have diabetes, you'll get a score of 2 if it's uncontrolled, if you have hypertension. So all these are like modifiable risk factors for dementia. not just Alzheimer's, but vascular dementia and all-cause dementia. And then I think it's a great tool to use more routinely. And then you can email me if you want a rough and tumble sort of mini book on brain healthier lifestyle. Happy to share it. I've written it with my wife, Faith Kalyana Desai. She's a psychologist. I'll end with this quote from the one and only Rainer Maria Rilke. Ultimately and precisely in the deepest and most important matters, we are unspeakably alone, and many things must happen, many things must go right. A whole constellation of events must be fulfilled for one human being to successfully advise or help another. I cannot emphasize this enough for Alzheimer's disease. You know, one could easily spend anywhere from 5 to 15 hours just talking to the patients and family members about how to go and live with Alzheimer's disease in the best way possible and how to navigate all this complex information. So I'll stop here and happy to discuss. If there's no questions, just for you guys to know, I have 175 more slides. Shukriya, dhanyawad, muchas gracias, merci. Dr. Eliason, I'll put you on the spot. Questions?
Yeah, I think we go with 175 other slides. I want to see what those are. No, I mean, gosh, the questions I would have are endless. Like a lot of times in the prison, right, we don't have access to the memory clinic.
Correct.
And that level of expertise, but we'll end up getting like a brand new patient that we know nothing about, who is, not communicating very well, but they're elderly, and then there's some kind of vague report of dementia.
Right.
But they can't advise us, they don't have any family, and there's no outside records. What do you think? What would you say is a good starting point for something like a case like that?
Yeah, it's definitely do a SLUMS, St. Louis University mental status, just to get a baseline cognitive functioning. Maybe repeat it just to see what the highest score is. Make sure, sort of as much as you can, that we've addressed any potentially reversible factors like nutritional deficiencies or thyroid dysfunction, hearing deficits, vision deficits. Get the score again. Try and do a FAQ, functional activity questionnaire, to get their function. It's again hard, as you said, if you don't have any objective information, but at least something you have, and then track it. This is Alzheimer's disease, and other neurodegenerative disorders are progressive. So depending on how long he will be with you, you might see a decline. And if in the future biomarkers become cheaper and FDA approved, then that might be an option in the future. But it's hard. If you can get a brain scan, definitely, just to make sure that we're not missing anything really reversible, hydrocephalus, brain tumor, so forth. A lot of vascular disease in the brain, especially of our prison population. And so again, it's good to see if that's the case. And then obviously, as rigorous a control of modifiable risk factors like hypertension.
But so just real quick, if I were to sum up, I think like the high yield stuff for like somebody with no outside information would be a clinical eval with the slum, and then possibly some brain imaging to make sure there's nothing real reversible, and the basic like dementia blood workup.
Yeah, that's it.
Okay.
That'll do it.
Sounds good. That's super helpful.
Good.
I think
Who
Dr.
else?
Velez, I think Dr. Velez has a question.
Yeah, let's put residents on the spot. I know Dr. Wheeling very well, so Dr. Wheeling, just be ready.
Hey, Dr. Desai, this is Dr. Wheeling. I'm not sure why our video isn't working.
That's okay. I can hear
But
you.
alas, I am still here. I had a question about kind of the logistics of the IV infusion of Leqembi. Like, how long is the actual infusion? Just thinking of the burden on patients going every 2 weeks, if it is
Correct.
multiple hours, that's a lot of time investment.
It is, it is. So they've calculated all this, Dr. Wheeling, and they've come up with like 40 days. So, you calculate how many hours and you multiply by 40 days. So you're right. It's highly intensive, lot of burden, not only on the patient, but the family members. The infusion itself takes, a couple of hours. And then you have to also go for MRI. You have to factor in, the anxiety about any dizziness or headaches you might get. You might have to go to the ED, uh, uh, and so forth. Yes, it's very burdensome. The new drug, they claim will be once a month infusion, so that would be a good thing. Donanemab, it's expected to get approved later this year. And they are claiming, they meaning the big pharma, that in some people, one could even stop the infusion after a certain time. So what they found in their study was that for like 34% of people, 1/3 of the group with intermediate tau. So that group, they're differentiated into high tau and intermediate tau. And in the intermediate tau group, 34% became amyloid negative. So all the amyloid plaques got cleared up. They could not see that in the brain scan in 6 months, and 71% it cleared up within a year. And a lot of experts are saying, if the amyloid is cleared up, then there's no reason to continue infusion. So all this is changing constantly. So we have to just sort of keep that in mind. But that study also showed that, the mild dementia population needs to be divided into two different sections. One with high tau, and again, in the future, we'll have biomarkers, either tau, PET scan, or CSF, something that will indicate that you have high tau. And then you would not be a great candidate because the high tau group did not separate from placebo in this donanemab group. But if you have intermediate tau, and maybe, the best case scenario is 6 months, once a month infusion. What do you think of that, Dr. Wheeling?
Well, I'm still thinking that only folks with high resources, not only financial resources, but that have family that can drive them to these appointments.
Correct.
Those are the people that are going to be able to get this drug. So great if it does a lot, but also a limited amount of patients are going to be able to benefit from it, from that standpoint.
No question about it. No question about it. And the way they're seeing this is that this is the first start of a very complex cocktail that eventually will come up for Alzheimer's disease. So they equate this to like how there was cancer treatment in the 60s and 70s, 1960, 1970. We had just started, and we have progressed so far now that people with cancer now, have amazing recoveries and live for a long time. So they're looking that very, very long term. And to me, a lot of the individuals who are currently undergoing treatment actively in many centers are like, going to influence what happens in terms of how safe it is and what's required. But you're right, it is, you'll need high level of resources, social and economic. And again, we can talk about the cost and whether that is ethically the right thing to do in terms of diversity, equity, inclusion, because Medicare won't pay $10 per session for brain and memory fitness programs at the local Y, which will come up to $800 a year, but will pay $3,600 per session, per infusion, $90,000 a year for this drug. So obviously something is very wrong with our healthcare system. Other residents, medical students, they get the first dib. You guys want me to call you out on their names?
Oh, we got a question.
Yeah.
Yeah, so the case that you presented at the start of your presentation sort of highlighted the maybe importance of like lifestyle interventions, like exercise, healthy diet, and Alzheimer's progression. So I was wondering what, if you're aware of, just is there evidence suggesting that like lifestyle interventions can reduce progression of like MCI to Alzheimer's disease?
Quick answer is no. Do I recommend it? Yes. So when you say, is there evidence, rigorous evidence? There you go. Good to see you guys. The answer is no. But we all do it. We all believe in it. So it's a strong yes. And again, just for you guys to know, in that donanemab group, 30% of people did not progress at the end of the year. All right, they were on placebo. Okay, so there is again a lot of variability in the disease progression, and this is what I tell the patients. Remember, to me, the first goal would be to support them and give them hope, because otherwise, it is every day is hard. And so these are the details that I tell them, that listen, even though there is no evidence, remember the evidence, they look at the whole group. So it's possible that there are smaller groups that really benefit from it. But then when you include the whole group, it just disappears, Also, it depends on where you are starting off with. If you're starting off with SAD, do you know what SAD means in terms of nutrition? Standard American diet. Capiche? So if your current diet is SAD, if you're shifting to all these things that Dr. Rebecca Chop is doing, right? All this MIND diet, Mediterranean diet, dietary approaches to stop hypertension, or just healthy, balanced, whole food diet, that person would see much more benefit to the brain in terms of dementia risk reduction, including at the level of MCI and mild dementia. But remember, the disease has been going on for 25 plus years before you get symptoms, all right? So honestly, then it won't be fair to do a 3-year study. By the way, they've done this, all right? So do a 3-year study on Mediterranean diet and say that it was no better than, the control group. It's, anyway. But yeah, factor all this in. Come on.
Thanks for that response. Yeah, that makes a lot of sense. Another question, sort of unrelated to that, but related to that infusion. One of the stats that jumped out at me was just the 20% risk of like brain swelling and brain bleed. And I wonder how you factor in these risks as you're recommending a medication may only have like a mild benefit in terms of like progression of Alzheimer's.
Correct. So yeah, so again, at our memory center, we have like on average, one discussion on lecanemab every day, and we expect that to go up meaning that we'll have more and more people in earlier stages coming and wanting to know what would be the benefits, like what you asked. And when they hear the whole thing, at this point, we've not had a single person who has said yes. Now, obviously, the other issue is money is an issue, right? Then they can't get it in Boise, so they'll have to like move their whole life to Seattle. And so those are the other barriers, but we don't even reach there. The reason they say no is for exactly what you said, that you don't have to worry about these brain bleeds. I understand you're saying that, 80, 90% of the brain bleeds are asymptomatic, but I'm still worried about it, and so forth. Our neurologist, Dr. River, has had one person who has, after getting all the information, said yes. The main problem was we don't have it available in Boise. And this is just my opinion, which means I could be totally wrong. But the person who's saying yes, the reason actually is emotional, not rational, right? So another way I see it, now I remember I don't know this person, so I could be wrong, but another way I see it is that they're saying that, listen, living with this, I just feel so demoralized, and every day is just hard. Whereas if I know that I'm getting this drug, then every day I tell myself that, hey, things won't be as bad. Hey, things won't be as bad. So a lot of experts have said, who are skeptical about this drug and are like, even the whole field is divided. So a lot of people say this is just terrible thing we are doing, for such limited benefits, we are spending incredible amount of resources, uh, uh, and we are giving false hope, right? And my perspective is, if for that person, it's not false. Every day they wake up looking forward to the day because they are getting this drug. And they could be doing all kinds of visualization exercises, right? That all the plaques are getting cleared up. I'll be that, outlier that responded dramatically. Do I need to go to each resident and ask? Do we have medical students? No?
I have a question. I'm
Yeah.
a resident. I'm curious. My name's Jordan.
Yeah.
I'm curious, like you kind of alluded to it, and I feel like I don't think you'd mentioned it this talk, but kind of like what the theoretical cocktail might be.
Yeah, correct.
Like what is are people
What?
talking about this? Like,
Correct.
is it to be like donepezil and this crazy drug and like the Mediterranean diet? Like, what would be the optimal solution? I don't know. Yeah.
Yeah. So two different things. When I was mentioning about cocktail, I was talking about disease modifying cocktail. So that's very different than symptomatic treatments, which is donepezil or, other cholinesterase inhibitors. So in these trials, people could be on these drugs that are FDA approved for mild Alzheimer's disease, dementia, right? The cholinesterase inhibitors. And I haven't seen any results that that group did better than the other group. But when I talk about cocktail, I mean, maybe next year we'll be giving lecanemab along with another drug that is like reducing inflammation in the brain. All right. So what happens is that this Alzheimer's disease is caused by this misfolded protein, A beta 42, right? So it misfolds and then it starts clumping like crazy, sticky. Then it forms oligomers, which start destroying the brain cells, synapses. Then it triggers inflammation. So the microglia start acting up. In some people, then this is a hypothesis, all right? The inflammatory hypothesis. In some people, the inflammatory system overreacts, and that's what's causing the damage, not the actual initial damage. So if you give a drug that will reduce that overreaction, then you would preserve a lot of these brain cells and synapses from being eaten up. So the next cocktail to add is this sort of anti-inflammatory medicine that works in the brain, right? That's another problem. What do you give that passes the blood-brain barrier? That's a huge problem. And then there are people who are Taoists. So Taoist means that they believe in Tao. They think it's the phosphorylated Tao that is causing all the problems, and you guys are focusing on A beta 42, but that's not the real problem. Look at these lecanemab and donanemab studies. You cleared the amyloid, and all you got was like a few months slowing, you know? That just shows that it's the phosphorylated Tau that's the toxic thing that we need to attack. And then you will have anti-Tau treatments. And then you will have, you know, who knows, all three, you know, anti-amyloid, anti-Tau, anti-inflammatory. And now there's a whole discussion of whether to make this Alzheimer's a biological diagnosis, all right? So the whole field is now coming to terms with what would that mean? So what they're proposing is that we change the definition from clinical to biological, meaning that, you know, at the age of 50 or 60, you could do a blood test or all these biomarker tests. If you're positive, then you have the diagnosis and then you stage it. So you say you are in the preclinical stage. And then you decide, you know, whether you want to just stick to lifestyle or you want to take part in all these fancy research studies that are recruiting people earlier and earlier, because the thinking is that the reason these drugs are not that effective is because you're coming too late. If you come earlier, then they will really make a big difference. Currently, what you're looking at is it's not like the person is improving. It's that the group on placebo is zooming down more faster. And that's why you see the clinically significant difference. And that difference for some people is not meaningful. MCID, meaningful, clinically important difference. They just don't think that's great for the amount of effort and cost. But if you start pre-MCI, all right, so now you can have a stage where you don't have MCI, but you have, like, say, subtle cognitive impairment that can be detected somehow on neuropsychological testing or other sophisticated computer testing. And you have other risk factors like family history or ApoE4 and all these subtle hippocampal atrophy. And then you have biomarker positive. And then you give all these drugs, you will maybe actually just never develop MCI at all. But again, you know, from psychiatrist's point of view, I would really urge you, one of you at least, to really go into this as early as is possible, because in the future, I can imagine that a lot of these patients will come to us in the pre-clinical stage. What do I mean by that? So remember, memory problems are just one manifestation of Alzheimer's disease. Depression, anxiety, apathy, personality changes, sleep changes, and they will be coming to you with, quote, major depression at the age of 60. And now you will diagnose them as major depression due to Alzheimer's disease. You will treat their major depression, but now you have to talk about the underlying cause and so forth. So St. Luke's has a band conference, Behavioral Aspects of Neurological Disorders. It's in end of March in Sun Valley. I'm giving a talk on blood-based biomarkers for Alzheimer's disease, because that's where I feel the future will be. We're just waiting for better tests to come with better sensitivity and specificity. We are not there yet. But again, you know, a lot of these patients will come to us first, presenting with the initial symptoms of Alzheimer's disease. There you go, Jordan. Very, very long answer to your one question.
I really appreciate that. You really, in my mind, like you like drew that clear link, kind of redefining neurocognitive disorders as similar to like cancer, which I think is really interesting way to
Right.
reconceptualize it. So yeah, that was helpful. Thank you.
For sure. Who else? Come on. You guys want me to give you the gift of time? Finish early?
I have one more question. I
Yeah,
think
go for it.
do you think you're going to open an infusion center, or is one coming to Idaho?
Yeah, it's coming. There's no question. You know, somebody's going to do it because the money, Jordan, in this is really crazy. But you have to line up so many ducks in a row that people have started to do it, but it'll take another 6 months to a year. So remember, you have the infusion center, but you have to also have an Alzheimer's expert available 24/7. Plus, you have to prepare the ED, emergency department, to know that if somebody is on lecanemab or this donanemab, they could have brain bleeds due to this drug. And also, if they have a stroke, maybe we should not be giving TPA because they will bleed and die, you know? So it gets so complex if the hospitalists and the emergency department, then the cardiologists have to be involved, right? Because if the person develops AFib after you have started lecanemab and they are put on blood thinners, anticoagulants, then the risk of bleeding from lecanemab will go up, and they need to be aware of that. So you just realize how complex it is. But again, I can't imagine not having it, because at this point, the only drugs that are coming out are all intravenous infusions. Any attendings? Residents, you guys are doing great. Let's see if any attendings have any questions. You guys are lucky I don't know you all in person attending. I would pull you out by name. It's all right. It's all good. All right. I'll give you the gift of time. 12 minutes.
I have a question really quick.
Yeah.
Would you ever recommend starting like an acetylcholinesterase inhibitor with just clinical suspicion of Alzheimer's disease without having gone through the whole battery of tests?
Nope.
Thank you.
To me, I think what I've learned, and I've probably done that myself, is underestimated the risks of acetylcholinesterase inhibitors and overestimated its benefits.
Thank you.
Yeah. And there is so much prevalence of anticholinergic drugs that it takes very little to block this modest cholinesterase inhibitor effect, you know?
What about memantine?
Yeah, same story, you know. We have a support group for being disappointed with these drugs.
Yeah.
Every year we are disappointed more and more. So it's painful.
Yeah.
Because we are in the Alzheimer's world, we are desperate. We are desperate to offer something, you know, biological, right?
Mhm. Mhm.
Just how we are. We want something biological that we feel is going to make a real difference compared to lifestyle and psychological and social interventions. I think we need all, but we are desperate. But yeah, memantine is another disappointment.
Okay.
Much ado about nothing. It has great psychological benefits. If it's not causing any side effects, a lot of my patients get a lot of psychological benefits that they are doing something, you know, they're just not letting this disease just gobble up their brain cells every single day. So, and the family members feel they're doing something.
Mhm,
That's just our culture. If you take a pill, then you're doing something,
mhm.
We
Thank
have a memory clinic at the VA, right? Anybody from there, or do they have different perspective than mine? I would be eager to know. It's all right. All right, well,
Hey, hi, Dr. Desai. Alan
hey,
Hines here. I thought
familiar
I'd just,
face.
I thought I would kind of jump in. This is trailblazing. I think what you're presenting, I'm feeling quite de-skilled, and so there's a lot to learn. It's a fantastic time to be in this field, and I would have to. There's a lot to learn, but as Dr. Zaleski was asking about some of the standard treatments, I was thinking about a gentleman who is on an acetylcholinesterase, and he is just declining. He's in his early 80s, and the question is, should we stop it? Because it doesn't but I thought the outcome on outcome measures with the use is delay in going into a nursing home, and so we decided to continue it. So because the fear is, well, when we stop it, we don't know what we don't know, and maybe there's worsening. So does that kind of logic make sense to you?
No.
Tell me more. Okay.
So there's a whole field of rational deprescribing. There's a lot of research that you will benefit more people from deprescribing than harm. But then this whole factor comes up. Remember, when I said psychological for the patient, there is also psychological for the prescriber. We
Yeah.
are so averse to doing harm that it's easier to do harm by not deprescribing. You want me to repeat that? It's easier to continue medicines
Yeah.
because it'll make us feel better, because if we reduce it and something bad happened, we will feel terrible. And so we continue all kinds of medicines in
Yeah.
geriatric population. And when they fall, you say, it's not my medicine, it's something else.
Yeah.
If they get confused, if anything negative happens, it ain't my medicine.
Good. Excellent. Thank you. Appreciate it.
You're welcome.
Thank you for all your work.
If anybody wants to open up a deprescribing clinic, I'll work there. All right. Thanks, everyone.
Thank you.
Ciao.
Thank you, Dr. Desai.
Thank you,
Thank
Dr.
you.
Desai.
Welcome.